Before we get into the program, just a minute. We have a full house tonight almost, and we have an overflow set up outside for people who are coming in late. They're looking for a place to sit. So, thank you for the great turnout tonight. Well, good evening. On behalf of the Focus on Seattle Committee, welcome. My name is Neil McReynolds, and I've asked to fill in for Committee Chair Roger Lead, who couldn't be with us this evening. I was pleased with the opportunity to fill in for Roger, because the Fred Hutchinson Cancer Research Center has been a special place for me during my 17 years on the board there. It's not what the board did, it's what the scientists at the Hutch have done to become world leaders in cancer research and many other fields of research. During my time on the board, especially over the years I served as board chair, I had the privilege of working with two outstanding individuals, one of whom is Don Thomas, our speaker, and the other was Fred Appelbaum, our speaker for this evening, and a member of Don Thomas's research team. Fred has just written a book on what Don Thomas accomplished on his way to a Nobel Prize. So another member of that research team was our own very active resident, George Counts, who will introduce our speaker for this evening. George?
Thank you very much. In September of 1975, the Fred Hutchinson Cancer Research Center opened on First Hill. Since that time, probably over 1.2 million persons have received bone marrow transplants around the world, with hundreds of thousands of lives saved for diseases, cancer, leukemia, lymphoma, and other diseases. All of it stimulated by the brainchild and hard work of E. Donald Thomas, Don Thomas. Our speaker, Fred Appelbaum, is a long-time dear friend and colleague. He received his training at Tufts Medical School, sometime at Michigan, and then a few years at the National Cancer Institute. So in 1978, he came to Seattle under the invitation of Don Thomas, and he's never left. And he's been at the Hutchinson for some 40 plus years. Currently, he is the Executive Vice President and Deputy Director. Please join me in welcoming Fred Appelbaum.
In the mid-1930s, everyone, and this includes physicists and chemists, felt that an atom was indivisible. I should say almost everyone. There was one guy, Leo Szilard. He was a brilliant physicist, and Szilard speculated that if a neutron hit the nucleus of an unstable isotope in just the right way, perhaps that nucleus would split. And when it split, it would give off energy and other neutrons. He then took that idea one step further and speculated that maybe if you had a fair amount of that unstable isotope, when a neutron hit one nucleus and it split, giving off energy and more neutrons, and those other neutrons hit other nuclei, causing them to split, giving off energy and other neutrons, you might have a nuclear chain reaction. And if you could capture that energy, maybe you could have a nuclear reactor, an idea that he patented in 1935, before anyone had ever split an atom. He took that idea one step further, and he wondered about the idea if you had a great deal of that unstable isotope purified and very close together, that chain reaction would happen all at once, releasing an enormous amount of energy, creating an explosion unlike anything that humans had ever witnessed. He kept that idea to himself. But then in 1938, Otto Hahn showed that, in fact, you could split an atom. Now, Szilard was a Hungarian Jew who had left Hungary when he saw the rising tide of Nazism and emigrated to the United States. Otto Hahn was a German in Hitler's Germany. And when Szilard found out that Hahn had actually split an atom, it scared the crap out of him. He didn't really know quite what to do, because he speculated that if he thought about this idea of a chain reaction giving rise to a bomb, it seemed highly likely that that same idea would occur to Hahn. So, not knowing what to do, Szilard went to the brightest man he knew, a friend of his, by the name of Albert Einstein. And he traveled to Einstein and he said, you know, if you could split an atom like they just did and it had a chain reaction, you could create a bomb. To which Einstein remarkably and famously replied, I never thought of that. When he did think of it, he wrote a letter. And he wrote a letter to the President of the United States, Franklin Delano Roosevelt. And that is how the Manhattan Project began. But the Manhattan Project, when it began fairly slowly because the United States was not at war. But then, in December of 1941, Japan attacked Pearl Harbor, and it was suddenly pedal to the metal. Within several weeks, the United States government moved a whole bunch of their best physicists to Chicago, to the Met Lab, including Enrico Fermi. So that Pearl Harbor happens in December. By January, there's already a group of physicists being moved to Chicago to see if they can actually create a self-sustained nuclear chain reaction, the first step towards the idea of a bomb. Well, all these physicists are showing up in Chicago, and they're going to be fooling around with radioactive material. And so the individuals in charge decided that they needed a doctor to look out after them. And they picked a guy who was a second-year resident, never been in a laboratory in his life. He actually grew up in North Dakota. His name was Leon Jacobson. And Leon Jacobson was pulled out of his residency to help care for these physicists and make sure they didn't get sick from radiation exposure. So Jacobson gets there again, joining this group in January or February of that year. By December of that year, they had created a sustained nuclear chain reaction. So it took them about 10 months to prove that that would happen. Now, the place that they did that was at the University of Chicago, and at the time, they did it in the abandoned squash court under the football stadium because it was a big concrete structure. Now, the football stadium was abandoned. It was the Alonzo Stagg football stadium, and it was abandoned because the president of the University of Chicago felt that football and academics couldn't possibly mix. Can you imagine that happening today? Actually, the University of Chicago won the Big Ten championship in football and was the home of the very first winner of the Heisman Trophy, Jake Burwank. But football was no longer being played at the University of Chicago, and so they had this abandoned squash court, which was a big place where there was lots of concrete around it. Now, the stadium is no longer there. But if you go to the University of Chicago and take a walk, right between the Mansueto Library and the Max Pavlov's dormitory, there's a plaque. And that plaque on the one side of the street says, this is where the first self-sustained nuclear chain reaction in the history of mankind took place. And if you turn around, there is a statue, a sculpture from Henry Moore. And that's my wife beside it. And that sculpture is actually a huge bronze mushroom. And it's called Atomic Power. Well, once they showed that a sustained nuclear chain reaction could be created, the next step was to purify an unstable isotope, U-238, and that was done at Oak Ridge. They also wanted to purify plutonium, and that was done at Hanford. And once they had the purified materials available, then they assembled the bomb, as you know, in Los Alamos by the fall of 1945. And in October of 1945, the atomic bombs were dropped on Hiroshima and Nagasaki. Now, when those bombs exploded, about 200,000 individuals were killed. About 80% of them were killed by the percussion and the heat of the blast, dying within seconds, some a few days from the injuries. But there were another group of individuals, about 20%, who were not killed immediately and actually didn't even appear harmed. But several weeks later, they started to show up in the hospitals with bleeding and infections, something that became known as atomic bomb disease. After the war, there was great interest in trying to figure out what atomic bomb disease was, because people speculated that this might not be the last time a bomb was dropped. So people started working in the laboratories, and one of the people that was working in the laboratory was Leon Jacobson, the second-year medical resident that was hauled out of his residency to take care of these physicists. He had never been in a laboratory before, but having been exposed to this, he became really interested and started working in a laboratory. And in 1949, he published a really important experiment. What he did was to take mice and radiate them, just like they had been exposed to the radiation that might come from a nuclear explosion. And the mice died 1 to 2 weeks later. And they died with bleeding and infection. But if he took the spleen of a mouse and exteriorized it, so it's still attached to the mouse by its artery and vein, but it's now exteriorized and put in a little lead cage. During the radiation, the animals recovered. He then showed that you could take spleen cells from one mouse and that wasn't irradiated and infuse them into a radiated mouse. Now, these were inbred mice, so they're essentially identical twin mice. And if you take those spleen cells from an unirradiated mouse and infuse them into a radiated mouse, that radiated mouse would recover. You could do the same thing with bone marrow cells from an unirradiated mouse into a radiated mouse. Now, we now understand that the reason this works is because there is a cell in your bone marrow, something called a hematopoietic stem cell. During your life, you will use billions and billions and billions of red cells, white cells, and platelets. They are the stuff in your blood. Your blood is actually a yellow liquid called plasma, and it has red cells, which carry oxygen from your lungs to your muscles, white cells, which fight infection, and platelets, which keep you from bleeding. These cells are short-lived. The white cells live for only a few days. The platelets likewise for a few days. Red cells for a couple of months. And so they have to be continually produced. And the place that they are produced is in the bone marrow. there are a population of cells, these hematopoietic stem cells, that sit in your marrow. They divide again, and they divide again, and they divide again, and eventually they make the red cells, the white cells, and the platelets that are all in your peripheral blood. Just to let you know how fast these are being created, every second you're producing about 2 million red cells, every second. So it's a huge amount of production that's going on. And so what happened with atomic bomb disease is that the radiation was killing those hematopoietic stem cells because they are the most sensitive cells in your body to radiation. And if you took cells from a normal individual that was unirradiated and infused them into an individual that was radiated, those stem cells, even if you just put them intravenously, miraculously know how to go through your arteries and veins, home to the bone marrow space, set up shop there, and do their job. And so that is what was happening with the spleen shielding experiment. Now, in mice, stem cells live both in the spleen and the bone marrow. In humans, they do too, but most of them are in the bone marrow, much fewer in the spleen, but that's just a species difference. Well, these articles that were being published in the late 1940s, early 1950s, didn't go unnoticed. There was one guy, particularly, who read them with great interest, a guy by the name of Don Thomas, Don L. Thomas. Now, Don, when he first read these papers, was just starting his fellowship and training at Harvard. He actually was born in a very dusty small town in rural Texas. The town of Mart had about 100, maybe 250 people in it. His dad was a solo practitioner whose first wife had died of tuberculosis. He remarried, and when he was 50, he gave birth, his second wife gave birth to Don. Don, as a small child, loved accompanying his dad, first in a horse and buggy and later in a Model T Ford when he would go on his house-to-house calls. And sometimes, as Don said, well, in rural Texas, you could drive when your feet were long enough to reach the pedals, for him, which was about age 12. And so he would take his dad on a trip when they'd deliver a baby, and on the way home, his dad would sleep in the back of the car while he drove home. He did this so often that even before he got to high school, people were calling him Little Doc. He really wanted to go to medical school, but his family couldn't afford it. And so he, after graduating from college, and while at college, he met Dottie Thomas, who was a freshman when he was a junior. That's when they met. Before they graduated from college, they had married. She was a journalism major. Now, he badly wanted to go to medical school, but he really couldn't afford it. But then World War II happened. And when World War II happened, a huge number of doctors were required to move from the United States to Europe and elsewhere to take care of the soldiers. And so there was an acute shortage of doctors at home. Because of that, the government created programs where they would pay for the training of individuals to go to medical school and also provide them with room and board. And with that, Don was able to go to Harvard. When he got to Harvard, they were so poor when he first got there that he had to live in a dormitory because the government would pay for that. And she had to live in a rooming house, and so they stayed apart for the first period of time. Eventually, Dottie got a job, and they moved into a small apartment in Cambridge. Well, while Don was doing this, he was working at Harvard as a hematologist. And while he was a hematologist there, he had a patient admitted to his service. And this was a patient who had renal failure. At the time, renal failure was a fatal disease because there was no such thing as dialysis. But this patient who had renal failure was interesting because he also had an identical twin. And a guy by the name of Joe Murray had the idea that maybe you could transplant a kidney from a normal individual into someone who needed a kidney if they were immunologically identical, since they were twins. And so Joe did that operation, and This is Richard and Ronald Herrick. He was the first individual to ever have a successful kidney transplant. That's them after he got discharged from the hospital. Richard recovered completely, married his nurse, had 2 kids, and was the first successful kidney transplant. Well, Don was observing all this, and he's saying to himself, you know, if you can destroy a normal bone marrow with radiation and replace it with a normal bone marrow, shouldn't you be able to destroy an abnormal bone marrow with radiation and replace it? And Lord knows there are plenty of abnormal bone marrows. Everyone that has sickle cell anemia, leukemia, lymphoma, immune deficiencies, all those diseases theoretically should be curable with marrow transplantation. Not only that, but if you could transplant bone marrow from one individual to another, you're also transferring their immune system. And so if you did a bone marrow transplant before you did a kidney transplant, then that kidney should be accepted by the recipient. So you should be able to do kidney transplants not just in identical twins, but in anyone. Now, when he proposed this to his boss, whose name was Sidney Farber, famous for the Dana-Farber Cancer Center, his boss said, no way. Said it's impossible. Everyone knows that you can't transplant tissue from one individual to another except in the very unique setting of an identical twin. People have been trying to do this for hundreds, thousands of years, and it's impossible. It won't work. And so you can't do it. I'm not giving you space, and I'm not giving you resources. Now, Don wouldn't accept that because, while what Farber said was true, wasn't absurd, Don also knew of one exception where tissues could be transplanted between individuals who are not HLA identical. This is a free Martin. Does anyone know what a free Martin is? No, you guys aren't from ranching territories. Okay, that's a free Martin. It looks like a bull, but it isn't. It's a female. And the reason it looks like a bull is because it is the product of a fraternal twin. A free Martin is when a cow has fraternal twins, one a male and one a female. Now, in cattle and in deer, unlike in humans and most other species, placentas fuse. And so the blood system is a mixture of both. And while the animal is in utero, the male hormones from the male circulate in the female and cause the female to become masculinized. And so the free Martin, when it's born, is sterile, doesn't produce milk, and obviously ends up as veal. It's useless for anything else. But the other amazing thing about free Martins is when you look at their blood system, it is a mixture of the blood of both animals, and it stays that way for their entire lives. And so the blood system from the male has engrafted in the female and doesn't cause rejection, it doesn't cause any problems. And if you take a skin graft from the male and put it on the female, she'll accept it because they're immunologically identical. And so Don speculated. He said, well, what if you create a in utero fetal-like condition by destroying a bone marrow and taking it back to its beginning and put in a new bone marrow into it? Could you create a system that looks a lot like a free Martin, where you would develop tolerance? Well, Farber didn't want to hear any of this. He said, that's too far out of an idea. Don was so committed that he quit his job at Harvard and moved to the Imogene Bassett Hospital in Cooperstown, New York. A small little hospital way up 4 hours north near Albany, about an hour from Albany. Now, the reason he went to Cooperstown is because there was another guy there by the name of Joe Farabee. And Farabee had the same idea that Don did about the potential for bone marrow transplantation, and in fact had been at Harvard where they had met and discussed over coffee that concept. And when Don couldn't get any leverage to do anything in Boston, he said, I'm out of here, I'm going to try it. And he moved to Cooperstown to work with Farabee. Well, he got to Cooperstown in 1955. In 1956, they tried doing bone marrow transplants. They did 6 of them. Every one of them failed immediately. They didn't know how to pick bone marrow. They took bone marrow wherever they could find it. In fact, the very first case, they took bone marrow from a stillborn infant. That's the bone marrow they used. Another case, they took bone marrow out of a rib where someone was having a thoracotomy. Another case was supposedly a resident who volunteered. Not sure how much he volunteered. But anyway, they got bone marrow. There was none of the marrow really engrafted for any length of time, and all the patients quickly died. Now, they had fatal diseases, and they were at the end stage of their lives, but nonetheless, none of them survived. And Don published that paper in the New England Journal. And in the discussion of the New England Journal, he wrote the following. In an atomic age with reactor accidents, not to mention stupidities with bombs, somebody is going to get more radiation than is good for him. If infusion of marrow can induce recovery in a mouse or monkey after lethal radiation, one had best be prepared with this form of treatment in man. The leukemic patient who needs radiation in bone marrow and the uremic patient who needs a spare kidney are the people who deserve immediate consideration. From helping them, one will be preparing for the atomic disaster of tomorrow, and it is high time that one did. I mean, the tone of writing in scientific literature has certainly changed. I don't think you could get away. I don't think you could get away with that today. But it was quite. I enjoyed the quote. Don realized, however, that there was so much he needed to understand, and he had to go back into some kind of animal model to figure it out. And he chose to work in dogs. Now, the reason he worked in dogs was threefold. Number one, they're an outbred species like man. They're not inbred like mice, and so they have the same differences immunologically one from the other. Secondly, they come in litters, and so you have the equivalent to brothers and sisters where you can actually try those transplants. And third, they're large enough where you can do kind of repetitive sampling of blood, and you can treat them just like you'd treat a patient. And Don was really interested in trying to develop a curative therapy. And so he started working in dogs. And what he found was that, in fact, you could radiate an animal, and if you took its own bone marrow and gave it back, the animal could recover, so-called autologous transplant. But when he tried to use bone marrow from a litter mate, most often the animal wouldn't recover. But occasionally, if he gave immune suppression after the radiation and after the infusion of litter bone marrow, the animals would recover. And one of them that recovered was Honest John. This is published in the Syracuse Herald American in 1959, and they presciently called it the Nobel Prize for test dog. So Honest John became a long-term survivor. But only occasionally would it work, and Don couldn't figure out how to make it work in every littermate pair or how to select the appropriate donors and recipients. He was working hard on it, but it just wasn't working all the time. In 1960, he came to Seattle to give a talk. And he came here because there was a guy by the name of Clem Finch, who actually had been his mentor back in Boston, and Clem had since moved to the University of Washington. And he's giving a talk in Seattle, and he's talking about the idea of bone marrow transplantation, but he's frustrated because he can't make transplants between individuals who aren't twins work. And in twins, if he does transplants for leukemia, the leukemia comes back. And so he really hasn't cured anyone with a marrow transplant. He finishes his talk, and just as he ends the talk, a young resident comes running up. And the young resident's name is Marino Robbins. And Marino Robbins says, "I have just the patient for you." And Don says, "What?" He said, "Yep, I have the patient for you. I have a little girl, 6 years old, who has an identical twin and has aplastic anemia. Now, aplastic anemia is where the bone marrow simply fails. There's no leukemia to wipe out. And because she has a twin, a bone marrow transplant presumably should cure her. And so Don says, that's really interesting. That makes sense. And so Marino says, well, let's go do the transplant. Now, Don's a visitor. He certainly doesn't have a license to practice medicine in the state of Washington, nor does he have hospital privileges. But these were different days. And so they go to the operating room, and they take Barbara, the normal twin. They aspirate bone marrow from her hip bones and from her shins. They take the bone marrow, they infuse it into Nancy. 2 weeks later, Nancy's blood counts have recovered. 2 months later, she's back in school, and her mother can't tell them apart. Nancy and Barbara, Nancy is certainly the first person on the face of the earth ever cured with a bone marrow transplant. Nancy and Barbara are still alive and well. They live in Tacoma. Nancy is retired from her job as a school nurse taking care of special need kids. Barbara has retired from being an occupational therapist. And they're still alive and well 63 years later after that transplant. I gave a talk at Town Hall several months ago about this, and Nancy and Barbara came to the talk and were there. It was great to have them there. Well, while this worked in identical twins, it didn't work if you didn't have an identical twin. And other people didn't realize that, and so people were trying to do transplants all over the country, even all over the world. And this is the number of transplants that went on between 1958 and 1966, and essentially none of those patients survived. It was estimated that almost 200 patients at different institutions, people tried transplants. Now, Don had not gone back into the human setting. He wanted to figure it out in dogs before he did that. Well, in 1963, he moves to Seattle. And the reason he moves here is because in Cooperstown, while Farabee was there wasn't a bigger department, and he realized he needed more scientists around him if he was going to make this possible. And so he moves to Seattle, and four of the people that he joins, three people that join him include Bob Epstein and Reiner Storb. These are both fellows who come to work with him, and Dean Buckner as well. And Epstein and Storb go work in the laboratory, and they want to figure out how to select donor-recipient pairs. Now, there had been a fair amount of progress that had been made in understanding compatibility in humans during that time. People were really hot on trying to do that because they wanted to make kidney transplants work predominantly. And what they found out is that if you took blood from one individual who'd had lots of transfusions, you could isolate antibodies that reacted with certain surface proteins in other people. And within families, you could identify who was more compatible with one another. And once they did that in humans, Bob and Reiner went back and mimicked those studies in dogs. And then they did this really important experiment where they took dogs and they selected litter mates who were either matched or mismatched. They gave the dogs total body radiation, afterwards a few infusion of the litter mate bone marrow, followed by immune suppression. And if the animals were matched, they all recovered. And if they were mismatched, they all died. With the ability to conduct transplant successfully between matched litter mates, Don was ready to go back into the human setting and start doing transplants for patients. And so he wrote a grant that paid for the remodeling of a ward on the old public health hospital, that specific medical center, that big orange brick building that you see on Beacon Hill in South Seattle. And it wasn't wasn't palatial, but it was a ward that had, he hired a nursing group. He hired Dean and Reiner to take care of the patients. Bob Epstein had left by that time. And they started doing transplants. The first group of transplants they performed in 1969 were 6 patients. None of them made it out of the hospital. These were end-stage leukemia patients, end-stage patients and a few that had severe aplastic anemia who were infected at the time. The next year, but the 6 patients, none of them made it out of the hospital. The next year, he tries 9 patients, and 7 of them don't make it out of the hospital, but 2 actually get discharged. With that, more patients are referred to him from family members who are desperate or other doctors, and the next year they go to 18 patients and then to 35. Finally, by about 1974, they have done about 100, a little more than 100 transplants. And this is the survival curve. Now, what this shows you is 2 things. This is the number of patients surviving, and this is time. Now, all these patients had end-stage leukemia. They are all going to be dead in a month or 2. And yet there are a group, about 15%, between 12 and 15%, who were cured. So Don is curing people who are otherwise incurable. But the other part of the curve is truly frightening, and that's the steep fall in survival. These patients are dying within months of the transplant, sometimes because of the transplant. So they're dying more rapidly than they would had they not been transplanted. But because they all would have been dead within months, Don proceeded with this. Now, it wasn't just Don. Now, the reason these people were dying was for a number of reasons. Chief among them was infection. These patients, when they come into a transplant, they already have no functioning bone marrow, and Don makes them sicker during the first couple of weeks because after the radiation, the blood counts fall before they start to come back up. And so these patients are developing bacterial infections. And we had a fairly limited armamentarium of antibiotics. They're dying of fungal infections. And at the time, we had only one antifungal agent, amphotericin, or as the patients called it, amphoterrible, or sometimes shake and bake because it was associated with such fevers and chills when you gave it. We had absolutely no antiviral agents whatsoever. And so there are these problems with infection. There are problems that the people, when we give them the radiation, they develop mucositis. And so they can't eat for a while. And there's no way to give them nutrients until Bob Hickman, working with Don, develops the Hickman catheter so we can start to give them fluids and IV nutrition intravenously. They're developing graft versus host disease because the only medicine we have to treat graft versus host disease was methotrexate. But Don persisted, and within a short period of time, other people started joining them. And one of the first, of course, was George Counts, who was so responsible for helping develop better antibiotics and learning how to help prevent some of the bacterial infections. And then Joel Myers came. At the time when we started, these patients, about 25% of them would develop CMV disease. And of that 25%, 12% would die of CMV. And we had nothing to prevent that until Joel came along and taught us how we could prevent CMV. There were a host of other advances, how to prevent the liver disease, and George McDonald came to help us. And so Don developed his whole small department of medicine, all focused on trying to make transplantation better. And over the years, it succeeded. These are just some of the high points, and I'll go through a few of these in a short order, of some of the landmarks in transplantation. In 1977, and I'll go and talk about each of these. In 1977, the first cure with autologous transplants. Then we started doing transplants earlier in the course of disease. Then we learned how to do unrelated transplants. And then we showed that transplantation could work for thalassemia and sickle cell disease. And just to give you a little flavor of those, I was at the National Cancer Institute when I first read about Don's work. And it occurred to me that if you could do transplants between twins, and you could do transplants in the setting of allogeneic transplants, if you had a disease that didn't involve the bone marrow, but was very sensitive to radiation, could you take one's own bone marrow out, treat the patient with very high-dose chemotherapy, and give them their bone marrow back and save them? And so we started doing autologous transplants, and I was fortunate enough to be the lead author of the first successful autologous transplants that were ever done. And this shows the cure rate in Hodgkin's disease and non-Hodgkin's lymphoma. Patients that would have been dead with these diseases but had autologous transplants after they failed conventional therapy, curing about half of them. When Don started doing transplants, the patients were terribly ill because they had active leukemia. And so he said, well, what if we did it earlier, when the patients are early on in remission, in first remission? Now, some of these patients could be cured in first remission, perhaps 15 to 18% of them. Could be as high as 20%. And at the time that he started this, there was a 30% chance of dying of a transplant. So he was asking patients who had a 20% chance of already being cured to undergo a procedure that had a 30% chance of killing them, with the hope that the outcome would be better. And so, of course, this was all done with informed consent, and patients were agreeable to this. And at first, it looked like this was a bad bet. 4 of the first 5 patients transplanted for AML in first remission all died. But the next 11 all were cured. And when he published the results for transplantation for AML in first remission, it appeared that instead of 20% being cured, now we were curing 60%. But in order to be transplanted, you had to have either an identical twin or a matched sibling. That was until Bob Graves showed up. Bob was a veterinarian, but also a very well-to-do cattle rancher from Colorado. And Bob shows up at John Hansen's office, knocks on the door, and he hadn't called ahead for an appointment. Calling ahead wasn't Bob's style. He just showed up. And so he shows up at John's office. He says, I have a problem. And John says, can I talk to you about it? And John says, well, okay, come in. And he says, I have a daughter, Laura, and Laura has leukemia, and she's going to die. She's going to die because she's failed conventional therapy, and she needs a transplant, but none of her siblings match her. But I happen to know, this is Bob talking, that Laura also has probably the most common HLA type. And even though HLA is very, very, very variable, the thing that we have to do to match for donor and recipient, even though it's very, very variable, she has the most common type, and I'll bet you could find an unrelated donor for her if you tried. And so John said, well, it's possible, but it's not up to me, it's up to Dr. Thomas. And Bob says, well, let's go talk to Dr. Thomas. Now, you weren't exactly in the habit of just walking down to Don's office at that time, but sort of emboldened by Bob's attitude, John walks down to Dr. Thomas's office, knocks on the door. They talked to Don and said, yeah, it does seem like a good idea. If we can find a donor, do you think it's the right time to do it, John? And John says, yeah, I think we can. Turned out that one of our techs on the 3rd floor actually matched Laura, surprisingly. And so we went ahead and we did the transplant, and it was successful in the sense that Laura had an uncomplicated transplant. She engrafted. She had no graft versus host disease or other complications. Unfortunately, her leukemia came back 2 years later, and she died. But Bob was so taken with the possibility that he started working day and night to try and create a registry of unrelated donors. Now, when that idea was taken to the government, they said, that's crazy. It's not realistic. HLA is so variable, you need a registry of millions of people. And it's just not time to do that. Well, about 9 months later, I got a call from a friend of mine, John Nanfro, from the Bethesda Naval Hospital. He says, I have a patient I want you to see. And that patient came out to see me, and his name, the patient's name was Elmo Zumwalt III. Now, Elmo Zumwalt III was the son of Admiral Zumwalt, who was head of all naval operations during the Vietnam War. And to make the story even more poignant, his son, Elmo Zumwalt III, had been a PT boat captain in Vietnam and been overwhelmingly exposed to Agent Orange, which had been ordered by his father. Now, his father acknowledged that, and to this day would say, and it's written, he said, you know, of course it causes me no end of pain. It's the first thing I think of when I wake up in the morning, the last thing I think of when I go to bed, but I still would have ordered Agent Orange because it saves so many people from being killed by snipers. Nonetheless, Elmo Zumwalt comes, gets transplanted, and the Admiral comes to stay with him while he's here, and he asked me, is there anything I can do to help? And I said, well, I'd like you to meet Don Thomas. He meets Don Thomas. And Don says, yes, there is something you can do. We could use support for a national marrow donor program. And so with that, the admiral figures out a way to get money from the Department of Defense to form the National Marrow Donor Program. And when the National Marrow Donor Program is formed, Bob Graves is the first chairman of the board, Admiral Zumwalt is the vice chair of the board, and today there are 40 million people who have registered to be bone marrow donors worldwide. And so we can find a donor for just about everyone in need because of really the pioneering work of Bob and Laura. In 1980, we performed the first transplant for thalassemia. This is Luca Loretta, who came from Italy, where thalassemia is a big problem. But his older brother had died of thalassemia, and so the parents knew how terrible the disease was. And we did a transplant to cure this disease, which tens of thousands of kids are born with every year. And it's very much akin to sickle cell anemia, which we did the first transplant. Actually, the first transplant we didn't do. One of our trainees did it in 1984. It was a young woman by the name of Kimberlyn George. Now, Kimberlyn had sickle cell anemia, but that isn't why she had the transplant. She had the transplant because she developed leukemia. And when she had the transplant for leukemia, we also cured her sickle cell disease. And so with that, we started doing more transplant for sickle cell disease as well. Well, in 1990, Don wins the Nobel Prize for his work. This is him receiving the award from the King of Sweden. And the number of transplants just continues to rise. Now, this is how many transplants were done when Don won the Nobel Prize. So it was already established, but you can see how much it increased over the years. And today, there are over...
If you're going to walk around.
Okay. Today, there are over 100,000 transplants that are performed worldwide every year, and they're performed in more than 80 different countries. So this has become a really worldwide thing. And outcomes continue to improve. This is the number of patients. This is all the patients. These are patients that we transplant for all stages of disease of leukemia, lymphoma. And you can see from 1990s to the 2000s to the 2010, our cure rates continue to improve and improve, even though the patients we're transplanting are older and have more advanced disease currently because there's other alternative therapies that people get first. And so it continues to get better and better. And it gets better and better for lots of different reasons, but as I mentioned, we have a whole team, a whole department of medicine, people like George who make infectious diseases less fatal, for people like George McDonald who help us overcome liver disease, et cetera, et cetera. Now, one of the things that came from transplantation, beyond just the ability to cure patients, was some of Don's legacy. And it goes beyond just transplantation. Believe me, if it had just been transplantation, that would have been enough. But it was much more than that. And this was one of the observations that was really important. What we found is after a transplant, the chance that the leukemia would come back was much higher if you had a transplant from an identical twin than if you had a transplant from somebody who was not an identical twin, a brother or sister. And if you saw an immunologic reaction of that new bone marrow against the patient, causing what's called graft versus host disease, you saw even lower incidence of recurrence. Now, if you take the immune cells out of the bone marrow, the relapse rates go right back up to what they would be with an identical twin. And the only way you can explain that is that the new bone marrow and the immune system that is recovering from it sees the leukemia as being foreign and rejects it. And that, in fact, is what happens. But unfortunately, it can also cause damage to the skin and the GI tract as it's rejecting the bone marrow. And so the goal then becomes, how can you harness the power of that immune system? And a lot of the work has been done at the Hutch and elsewhere, where at first we recognized this graft versus leukemia effect. And then we found out that if you just take lymphocytes from the donor and infuse them to the patient, sometimes the leukemia will go away. Then could you find the lymphocytes that were specifically reacting against the leukemia rather than just take non-specific lymphocytes? And once we could do that, then we said, well, can we actually generate the lymphocyte we want by putting the receptor into it that sees the leukemia, instead of having to hunt for them, generate our own. And so that is what is being happened. These are some of the people that were key in that: Alex Pfeffer, Mac Cheever, and Phil Greenberg. And today, we have this ability to have a patient who has leukemia or lymphoma, to take out lymphocytes, to genetically insert into those lymphocytes the receptor that sees the leukemia, to grow those cells, and then give them back to the patient. This is something called adoptive immunotherapy or cellular immunotherapy. There are now 6 products that have been approved by the FDA. This is one of the early young girls who 10 years cancer-free now after getting her getting her CAR T cells. And when I last looked at clinicaltrials.gov, there are over 1,087 clinical trials throughout the world that are exploring these kinds of adoptive immunotherapies. And interestingly, only half of them are for lymphoma and leukemia. The other half are for solid tumors. And so we were doing these now for diseases like brain cancer, pancreatic cancer, other kinds of malignancies. And so that's one big legacy of Don's work. I don't know if you saw the headlines in the New York Times last week, but the FDA just approved a new kind of CRISPR gene therapy for patients with sickle cell disease. Saw that? Well, this is the first woman that ever got that kind of therapy, Victoria Gray. Now, we showed that you could cure sickle cell disease by doing a bone marrow transplant. And so the next question was, well, instead of using someone else's bone marrow, could you do an autologous transplant by taking out the person's bone marrow, fixing the abnormal gene, and infusing the fixed bone marrow back into the patient? Now, there's 2 ways that you can fix the abnormality. One, you can put in a normal beta globin gene, and that has already been approved by the FDA. And what they will approve based on the hearings last week is a different kind of gene therapy where when you're in utero, you make a different kind of hemoglobin. It's called fetal hemoglobin. And just as you're born, you switch from making fetal hemoglobin to adult hemoglobin. And so what they do here is they take out the bone marrow and they just wipe out the switch. And so you start making fetal hemoglobin again. And you're just fine with fetal hemoglobin. And so by having fetal hemoglobin, you get rid of the sickled cells and all the symptoms of sickle cell anemia go away. And so another one of Don's legacies is gene therapy. This is transplantation. This is an autologous transplant. And if Don hadn't done what he did, we would not be doing this today. Another cure is diseases of immunity. This is the first patient on the face of the earth ever cured of HIV, of AIDS. His name is Timothy Ray Brown, the so-called Berlin patient. And like Kimberlin George, he did not get a transplant for HIV. He got a transplant for leukemia. But the donor had an unusual kind of lymphocyte that does not permit HIV to enter into it. And this is not a disease, it's just differences. And it's not very common, but there are people that have this deletion in a certain gene that is normally the door that HIV uses to get into cells. And so when Tim got a bone marrow from a donor who had that unusual form, his HIV went away because he had now a new immune system, and he was able to get off all anti-HIV medications and live free of HIV. And now there are a number of other individuals who have had this, and we are trying to engineer bone marrow in patients' own bone marrow to render the lymphocytes impervious to HIV, and another potential cure from Don. And now there's many different kinds of immunotherapy, diseases of immunity that are being treated with bone marrow transplantation. Another one of Don's legacies was the stem cell transplants. Now, Don transplanted hematopoietic stem cells, but you have many other kinds of stem cells in your body. You have bone stem cells, you have muscle stem cells, you have pancreatic islet cell stem cells. And if you can transplant bone marrow, shouldn't you someday be able to transplant these other forms of stem cells? And in fact, this is being done. There is one kind that has already been approved. These are transplanting islet cells. This was approved just a few months ago for diabetes. There are some really exciting work in Parkinson's disease where a group is transplanting the stem cells that are the ones that make dopamine and curing Parkinson's by transplanting these into the brain. Muscle stem cells, heart stem cells, it's really going to be an amazing area of science, the so-called regenerative medicine. And finally, one of the things that Don wanted to do was to do bone marrow transplants so that you could subsequently do a kidney transplant. Well, that didn't actually take off very quickly. But now people are working seriously about this, and there was a recent paper from the group at Stanford. When you do a kidney transplant, the average life expectancy of that kidney is only about 10 years. So if you have a kidney transplant, you probably have to have a second transplant or a third transplant, depending how old you are when you get that first transplant. And so that puts a huge burden on the number of available organs. Plus, you have to be on potent immune suppression for the rest of your life. Well, the group at Stanford has now done 27 patients with a bone marrow, what's called a very mini bone marrow transplant, right before they do the kidney transplant. And of the 27, all are alive, and 24 of them are off all immune suppression with totally stable kidney function. And so this could be a game changer, not just for kidney transplants, but for heart transplants, liver transplants, you name it. So another bit of legacy from Don Thomas. Well, it isn't, of course, just Don. It's a team. This is, Don died in 2012. This was taken a few years before that, but this is just some of the members of the team. And I would say that when I talk about the team, I'm not talking about just the scientists and the physicians, but I'm talking about the nurses. I just can't say enough about the nurses who are with these patients, particularly early on when 80% of our patients were dying, and the nurses were there and stuck it out. And many of these nurses still are involved with the Hutch. They have a monthly nursing retirement luncheon where all these old nurses get together. I've gone to a couple of them. It's just great to see them. Some of them are still working. When COVID hit and we needed volunteers to come in and start giving the vaccines, it was our transplant nurses that came back out of retirement and just worked to give the vaccines. Plus, it's the technicians and it's the dietitians and the pharmacists. It's quite a group that allowed this to happen. So I just want to give a special thanks to the mid-level providers, the nurses, pharmacists, dietitians, schedulers, social workers, other members of the care team, and of course to the patients and their families. And I also want to thank Neil and George and for the rest of you for inviting me to share this information with you. And I'd be happy to answer any questions. Thank you. Oh, thank you.
Excellent, excellent. So, your hands are going up already here.
I had the privilege of visiting while they had the clinical setting, the wards up by Swedish,
Right.
and they had something called laminar flow. So you have engineers that were helping you and HVAC people too.
Absolutely.
So tell a little about what the purpose of the laminar flow was and why it worked and how it came about.
Sure. So as I was mentioning, when we were first doing transplants, our armamentarium for treating infections was quite limited. And despite the best efforts of George and colleagues, we still couldn't treat many of there were a lot of the infections we couldn't treat. And so the idea was, could we keep the patients from ever getting infected in the first place by putting them in a laminar flow room? Now, a laminar flow room is a room where the air is filtered and goes in, it's called laminar because the air is pushed in layers so there won't be any eddies where the dust can collect. And so it comes in one place, it's filtered, and it goes out. When the patient goes into the laminar flow room, they are given an antibiotic bath. They are given powders. We try to, essentially, they're given non-absorbable antibiotics to clean their gut. So we try to make them as sterile as possible. All the food that comes into the laminar flow room has to be sterilized. And so we learned how to do that. And it turns out that if of course you can pasteurize it, but who wants to eat canned food, you know? But we found out that you actually could radiate food and sterilize it, and it works. Now, if your food is sugary, like apples and fruit, it tastes just fine. You can't notice it at all. But if there's a lot of fat in it, like fatty cheese, the radiation oxidizes the cheese. It takes rancid. So we used to have tastings, like a wine tasting, where we taste the radiated food to see what tasted okay before patients go in. Now, to go into a laminar flow room, you as the physician had to walk up. You had a little packet. You opened it up, and then the first thing you did was you put on your gloves. And then your gloves, you put out a little piece of paper, you lay it on the floor, and then you take out a booty, and you put it on one foot, and then you step on that, then you take the booty, put it on the other foot, and then you have to put on, it was like a little dance. Every time you walked into the floor, every time you walked into the room, you had to do that. But it worked. I mean, it did prevent patients from getting infected. But as time went on, but it was very tough on the patients. I mean, they stayed in the room for 50 days without human contact. But eventually, our antibiotics got so much better. We found that we no longer needed laminar flow rooms. And so when we left First Hill and moved to the new units, we no longer needed laminar flow. Now, we still have positive pressure rooms, but we don't have laminar flow. And the entire ward where we do the transplants is air filtered, and nobody that has any infections can, of course, come onto the ward. Everyone's screened before they come onto the ward.
Other questions for Fred? Okay. We have a microphone. George has got one there, so right over. There you go.
Could you tell us briefly, what are the mechanics of getting bone marrow in and out of a person in an autologous situation?
Sure. Great question. In the past, we got bone marrow from where it is in the bone marrow. So, which is mostly the places where bone marrow is most available is in the hip bones. And so we take a needle, which is a pretty thick needle, and you press it into the hip bone, and it goes through the top layer into the middle, and there's this sort of spongy area in the middle, and then you aspirate up the bone marrow. Now, the patient is under general anesthesia or spinal anesthesia when we do this, but you have to go into the bone probably 50 to 100 times. Now, patients ask me whether it hurts, and I said, yeah, you know, after about 30 minutes, my hand really, it gets... I don't actually say that. The patients do get, it takes about 3 or 4 days. They feel black and blue around the hip bones, but by about a week, they're back to normal. Now, it turns out that we can make these stem cells that are normally in the bone marrow leave the bone marrow and go into the peripheral blood. And we can do that by giving a medicine called GCSF or Neupogen. After about 4 days, there's a very quick peak of these stem cells in the peripheral blood. And so then what we can do is, instead of having the patient have to go through this procedure, we can put a needle in one vein, take blood out, put it into a centrifuge where the stem cells are taken out, and then the red cells and plasma go back into the other vein, so it's a continuous flow. And after about 3 hours, usually we can get enough stem cells for a transplant. We can also get stem cells from cord blood. So it turns out that cord blood is very rich in hematopoietic stem cells. And normally it's just thrown into the garbage. And so there are now cord blood banks that have been set up by the government where there's over 100,000, over 1 million cords that have been stored, and we can use those as well. So cords, peripheral blood stem cells, bone marrow, they are all a form of hematopoietic stem cell transplantation. They're sometimes called different. Sometimes they say it's a stem cell transplant, some type of bone marrow transplant, sometimes a cord blood transplant, and those are subtly different. The source, but the general principle is the same. You're transplanting hematopoietic stem cells.
Well, thank you, Fred. Got a question at the other end of the room down here. Raise your hand, George. We got a, yeah, here you go.
Has anything been done in studying the patient experience? I mean, it must be very stressful, and for a number of reasons,
Sure.
including the uncertainty of the experience. And it seems to me to be wonderful to be able to find out a little bit about how people have adjusted.
Sure. So we have a very robust research program that includes such things as long-term outcomes, including physical, social, financial well-being. We have psychologists, we have economists, a whole bevy of people that work with us to try and answer those questions. You're absolutely right. You know that when we started, we were focused on one thing. When Don started, we were focused on one thing and one thing only: cures. But you know, it soon became apparent that cure wasn't enough. We had to have people that were cured, but also that returned to good health, that had, you know, that got back to a life that, a quality of life that was. But you're absolutely right. We do pay a lot of attention to that issue.
There was one particular thing that interested me.
To the microphone. The mic.
There was one thing that interested me particularly, and that was what kinds of social support are helpful to people. I mean, just to tell people, you know, you're going to get better, that might be fine for some people, but not from others. But do you know anything about what works?
Sure. Yeah. So so I'll tell you one little anecdote and then answer a little bit more. So when Don first started doing transplants, early on, one of the patients that was referred to him was a young guy by the name of Steve McCarty, who was a 10-year-old who had aplastic anemia. And his mother, Marion McCarty, came up with Steve while Steve was getting his transplant. Marion was a social worker from Southern California, and Steve had his transplant and did very well. And as Marion was and Steve were getting ready to leave, Marion walked up to Don Thomas, and she said to him, "You need a social worker." And Don said, "I probably do, but you know, I can't afford it. You know, we don't have." And Marion says, "Well, that's okay. I'm going to move to Seattle. I'm going to become your social worker." And Don said, "But I don't have a salary to pay you." And she says, "That's okay. I'll do it for free." And for 2 years, she became the first social worker at the Fred Hutch and did it gratis until Don figured out enough money to pay her. And so it is a big issue. And there are things interventions that have been tried, and some of them work. There have been other interventions that don't work. These interventions including having physical rehabilitation, having social workers meet with people after the transplant to help them through. And so lots of randomized studies addressing those kinds of issues.
I think we should salute the bravery of the patients. I went through it as a hospital chaplain in the 80s, and it was hell for the patient and the family. I went through it again in the 90s with another person. They did wonderful. That 10 years made all the difference.
Absolutely. You know, those early patients and what they went through, it's just hard to fathom how sick they were. But, you know, I think that is why Don really tried to do everything he could to soften the blow, to make it better. But, you know, when you're trying something for the first time and your tools are limited, but you're absolutely right, for sure.
Other questions?
What happened to this work when stem cells became such a political issue and people were against the idea of using stem cells in research and medical care? Did this work get set back by that?
This work did not, because there are different, this is, I'll take a step back and give a little background here. The idea of a stem cell is sort of a complicated idea. We all began as a single cell, a fertilized egg, one cell. That's a totipotent stem cell. It can do everything. As you grow in utero, some of those cells decide to become heart, and some muscle, some brain, and some bone marrow. By the time you're born, you do not have any of those totipotent stem cells left. All you have is organ-specific stem cells, the cells that, when you cut your skin, cause the skin to heal. When you take out bone marrow, replaces the bone marrow. The thing that people objected to in the 80s was the idea of embryonic stem cells, the stem cells that were from the very early embryo. And the only way that you could get those at the time was by taking embryos that had been discarded. And people had philosophical or religious concerns about that. And so they put a halt to that sort of work. That didn't apply to bone marrow stem cells because those are adult stem cells, so it's a different issue. It did put a damper on research at the time, but science, being science, figured out a way around that, and now we can create induced pluripotent stem cells. So we can take out your skin, a skin cell, and we can put in certain things that turn it back into an embryonic stem cell without having to sacrifice an embryo. You can also create stem cells by taking the nucleus of one cell and putting it into an egg and then letting that grow. And that's how Dolly, Dolly became the first cloned sheep by doing that. But the political issues of embryonic stem cell research are now, they've died down and never affected bone marrow transplantation.
Speaking of the patient experience, that was such a great question earlier. Can you talk a little bit about the changes that were made in Clinic Building 2 with care neighborhoods?
Yeah, so the thing that Don did was to show that your therapy needs to be really focused around the patient, and you need a whole team to take care of the patient. And so we built an outpatient clinic Don built an outpatient clinic where it was centered more around the patient than around the caregivers. And a few years after that, when we got a very nice gift from the Bezos family, we created another immunotherapy clinic that was next to the transplant clinic. And what we do there is we have the patient, instead of coming into the clinic and having to go one place to have your blood draw and go to another place to have to see the doctor and a third place to have your infusion and a fourth place, you know, et cetera, what happens is the patient just comes in and goes to one room. And in that room, they have their blood drawn, their vital signs taken, the doctor sees them, they get their infusions. So it's really much, much more patient-oriented. And given that, when we saw how well that worked for patients, we said, well, why are we just doing this for transplants and for immunotherapy? Why don't we do it for all patients? And so when we just built our new expansion of our clinic at South Lake Union, that's how all the clinics are organized around a care team around the individual patient.
George, did you have another one? one back here. Yeah.
In the midst of this serious discussion, excuse me, it's probably important to note that updates you on football at the University of Chicago, it has sadly returned.
I did not know that. Is it an intercollegiate football or is it just a club sport?
It's community college.
Oh, okay. All right. Thank you for that.
25 years ago, a friend of mine had leukemia and needed a bone marrow transplant. So I went on the registry, and we were not a match. But my question is to you, is there any age at which they will no longer take your bone marrow? Did I hit that age?
That I can't answer. But we tend not to use. I think the limit now is 60, and it may have dropped to 50. So and we of course, our goal is to never put a donor at risk, and so with age, unfortunately, what can I tell you? The risk becomes a little bit greater, and so we tend to limit. Interestingly, also, younger donors do better. Patients do better getting with younger donors. Patients also do better with male donors than female donors. I'm not going to say anything. No, actually, it is mostly female donors who have had kids. So if you've had multiple children, one of the amazing things in biology is that a woman can carry a baby to term. I mean, it's a foreign organ in there. I mean, immunologically, the baby is foreign. It's not you. It's half you and half the husband, or half the father. I'm trying to learn, but it gets harder and harder. So the father, so the woman, there's a very unique immunologic reaction of the woman that is able to not reject the fetus. But even so, the woman does become sensitized to the foreign proteins of the fetus. And so you can find when they then would be used as a donor, their immune system might see more things in the patient than it would if it hadn't been exposed to the fetal antigens.
George, you got a question back there? Yeah. Way in the back, Jeff.
This is a wonderful story you have to tell us, but you're also a wonderful storyteller.
Thank you.
It's very complicated stuff you've made accessible, and I've noticed the times when you've stopped and took a breath and figured out, how do I tell this better? It's just fantastic. One thing I thought about as you were speaking, though, was increasingly disturbed about, was you were calling it Thomas's legacy, and it's really the story of science as a collective enterprise, which you made clear at the end. But really, if it weren't for it was his obstinacy, I think, that distinguished him. But after that, it took Imwald Zimwald. It took, the veterinarian and his daughter. It took so many people in order for this to come together. It's almost as if the problem is a Nobel Prize, which requires us to recognize a single person for what is almost inevitably a collective enterprise.
I think that's absolutely true. So first of all, if you were to ask me what Thomas's characteristics were that allowed him to be successful, I agree with you. I think one of them was focus. When other cancer centers were early on, Don was the first director of clinical research and clinical care at the Hutch. In the early 70s, we were one of the 8 first comprehensive cancer centers that were formed by the Nixon's war on cancer. What Don did was to develop transplantation. Everyone he hired was working in transplantation or leukemia. Other centers were trying to do everything. They wanted to do breast cancer and colon cancer and lung cancer. And so they became, a mile wide and an inch deep. That wasn't Don's approach. He was going to focus. And so that was number one, focus. Number two, as you mentioned, absolutely persistence. He just was very persistent in this. And I once asked him, I said, did you ever think of stopping? And he said, well, if I had really come to a dead end where I couldn't figure out the next experiment or the next thing to try, yeah, I probably would have moved on to something else. But I never got to that point. There was always another experiment to try or another avenue to pursue. The third thing was the team approach. I think, it's a focus, persistence, involving a whole team. And he was so gracious. I mean, George will back me up on this. He always would deflect praise onto other people and give praise to everyone that contributed. And finally, Don also was really interested in learning his whole life. When I was doing work in antibodies, he came to my office and said, Fred, can you explain this to me? I mean, he wasn't embarrassed. He would sit down and, you'd spend half an hour with him telling him what you're doing, and he asked great questions. He was always constantly learning, and I think that's a great characteristic as well. But you are right. The Nobel Prize goes to one person. Now, sometimes it goes to a person who wins a race, and there's 4 people in the race. And in fact, Dudna got it for CRISPR. If she hadn't gotten it, Zahn would have gotten it, who was doing the same work, and there was a race to get there. In Don's case, there wasn't a race. There wasn't anyone else doing it. And so I do think in some cases there's a little more of a unique personal stamp on it than in other cases. And I think Don, of course I'm biased, what I'm going to tell you. And by the way, you saw this before, but if you want to know more about the story, this is the a book that I published this year, and I'll leave a copy for the library here if people want to read it. Or there's always Amazon.
Got time for one more question. I think we're down over here. I see a hand.
Yeah.
Thank you.
Sure.
Super. Get this out right.
Yes, your answer about it being so focused on the transplant, now that you have combined Cancer Care Alliance with Hutch, is Hutch going to do more research in cancer or have a different focus, especially with the neuroendocrine cancer?
So since Don's time, Don really was the director from the 1970s up till about 1985, when he retired, I guess 1986. Since that time, we haven't given up our focus on transplantation for sure. We still are the leading transplant center in the world, but we have worked hard to try and develop that same kind of excellence in all the other major tumor types. We have a wonderful program in prostate cancer, a growing program in breast. We recently received a SPORE grant, which is a site of excellence award from the NCI in lung cancer. And so we have many different areas of cancer that we're working really hard in. So we've become much more of a full service bank now, and that's been an evolution over the last really 30 years, so it isn't brand new. Don's work, when he focused solely on transplants, was from about 1970 to about 1986, 87, and then we quickly became much more focused. Now, neuroendocrine tumors, we do have an interest in. It's a tough area, but there's a lot of interesting new approaches that people are exploring in that arena.
Well, thank you very much, Fred. That
Can I
was
just say
terrific.
one more thing?
Sure.
If any of you have questions or concerns or family members or anything that you want help with, and you can always contact us, and we'll be sure and try and get you the help that you need. So.
I appreciate that. Thank you very much. Terrific job, man.